Okay, good morning and welcome to the VHHA-sponsored webinar on stopping sepsis in Virginia. I would just like to review some general housekeeping items with you all before I pass this off and we get started, just in case you are new to this platform. Slides were sent out this morning to those that were registered. If you registered late, you can also access the handouts in the handout section of the GoToWebinar platform. This webinar is being recorded so it can be shared with others who are unable to attend live. We do ask that you please dial in using the telephone option if you are able. You will be prompted to enter an audio PIN, and this will allow us to have a discussion at the conclusion of the webinar. At this time, all participants are muted and all panelists are unmuted. If you do have a question, we ask that you hold that question until the end of the webinar, but you may do so in two different ways. One, you may raise your hand using the palm with the arrow on it in the GoToWebinar platform. Hopefully you can locate that now, and I ask that you practice using it so we can be sure that you will be able to ask questions later. It is located on the left-hand side of the Grab tab. Please do this if you are dialed in with the telephone only. If you are dialed in with either the computer's audio or using the telephone, you may ask a question by accessing the Questions platform, which is also located on the tab menu. And with that, I will turn this over to Wanda Clevenger, Director of Performance Improvement, to begin the webinar.
Great. Thank you, everyone, for joining today. I'm very happy to present our third hospital webinar in the Stopping Sepsis in Virginia Hospital and Nursing Home series. So today's objectives, we will be having a hospital spotlight of best practice. We have with us today a dedicated sepsis coordinator who's going to talk about her role. And also we're joined by Kathleen Volman, who will be discussing early recognition through screening. I'll be providing Stopping Sepsis project updates towards the end of the webinar, and then we'll just briefly touch on next steps. Whoops. Okay. Thank you. Here's our sepsis support team. As you know, this is a project that involves both the nursing home setting and the hospital setting. So from HQI, Deb Smith is the improvement consultant who's the project coordinator from HQI, and Deb Smith is on the line today, so if any nursing home related questions come up, she'll be able to answer. And also Candy Hamner is an improvement consultant with HQI who is helping to guide this project and the nursing home work. From VHHA, we have Betsy Cole-Archer, myself, and then also Kathleen Volman is the sepsis content expert who is providing guidance and national perspective for us as we work to improve sepsis outcomes. So before we begin, we'd like to do a, whoops, hold on one second. There we go. Okay, before we begin, we'd like to have a quick survey. And as you know, we're going to be talking about the dedicated sepsis role. And so our first survey question is, do you have a dedicated sepsis coordinator at your facility? And I know as I've gone out to organizations, this has been a issue that I have really supported because I think the role is so critical. And as you'll see from Ashley's presentation, it's made a big difference in how sepsis is managed, what the sepsis outcomes are at her facility, and also reductions in length of stay. So the poll results are looking that 32% do have a dedicated sepsis coordinator, 53% do not. So that's something as part of this project we'd like to see improved upon. And we have some people that aren't quite sure because I know at hospitals many people end up wearing multiple hats. So with that, and we'll probably have that survey results again at the end when we take questions. I'd like to introduce Ashley. Ashley is a dedicated sepsis coordinator at Lewis Gale Hospital, Montgomery, and she kindly responded to a request to share information about her hospital and how they came about to create the role of dedicated sepsis coordinator, and Ashley is going to talk about what that experience has been like and how she's implemented the role. I would, before Ashley begins her presentation, just a reminder that Ashley, we will take questions at the end of Ashley's presentation. So if you have a question, just hold on to it, or you can type it into chat, and then we will have some time to respond to those. So with that, again, I'd like to welcome Ashley and look forward to hearing Ashley's presentation. So Ashley, you have control of the screen, and please proceed.
Thanks, Wanda. Good morning to the group. My name is Ashley Day Costa. I'm a tenured ICU nurse and also am the sepsis coordinator here at Lewis Gale Hospital, Montgomery. So the background of our story is that we started in January of 2015, and we had a mortality rate issue. Our mortality rate for septic shock was in excess of 52%. And what we thought about severe sepsis, septic shock, or any sepsis presentation on the continuum is that it had subtle signs coupled with a multitude of other disease processes that carried the same signs and symptoms, did not lend to easily recognizing the illness. Little sense of urgency was found in implementing care, which was an indication that education was needed. And the vast majority of sepsis patients were coming through the emergency room, and only about a quarter of them were being identified appropriately and upon admission, which is where the biggest difference is made with this patient population. And in a review of mortalities indicated that a large portion of the deaths were related to sepsis, which was very eye-opening to the facility. So prior to my role, we're having a dedicated full-time sepsis coordinator in the building. We attempted to reduce mortality for 2 years. We had already implemented a sepsis screening tool, electronic order set bundles, and provided education to all staff members, but reductions in mortality at that time were not recognized or realized. Further, true compliance with calling overhead sepsis alerts wasn't happening. This led to a decision to develop a dedicated sepsis coordinator role. And so the qualifications that went into the role itself were to have a tenured critical care nurse with expert critical thinking skills, a solid foundational knowledge of sepsis epidemiology and treatment, and it's strongly recommended for previous experience in the realm of sepsis protocol implementation, and the ability to influence behavior and practice of coworkers. And I started in December of 2015. So the influence piece is the biggest piece. You have to develop, the person should or have to develop long-lasting positive relationships to earn the trust of colleagues in a very short amount of time. Utilize a non-aggressive approach and willingness to work alongside staff. Kind of act as a relief at times to staff caring for the critical care patient, because the sepsis population, the vast majority of them are critical care patients. And also to be able to assist nurses in caring for their load while taking care of others of the sepsis patient that the sepsis coordinator is there for. So my role can be kind of divided at times. I may go around the emergency room, even taking care of other patients while that nurse is one-on-one with my sepsis patient, and then follow back up with him or her. Also to coach and mentor at the bedside, be able to walk the talk with them, give guidance and direction while alongside of them, and build a bench of sepsis champions at the unit level through engagement and influence. And so it started. Co-sepsis drills were underway. The biggest concerns that we identified were during the off hours. So I came in the off hours, both the ER and inpatient units, and did in-house drills weekly. They were done as though they were in real time with overhead calls. Scenarios were presented at those overhead calls with verbal quizzing and cueing, and everyone was included, respiratory therapists, residents, and all nursing staff. I even include tech staff or CNA staff. I don't know if you have those at your facilities or not. Sepsis drills were conducted at night, early morning, and on weekends. Emphasis was placed on the why behind the what, and that was most important because what I really wanted them to understand is that sepsis is not an infectious problem. It's a perfusion problem, and it's a perfusion emergency. Uh-oh. So the year-to-year comparison, when you look at 2015 into 2016, we had a tenfold increase in our sepsis alerts. 2015, we went from 160 to 495, and then had a tenfold increase from 13 in 2015 per month to 41 in 2016 per month. And then increased recognition led to increased bundle compliance. As you can see, the positive trend in our bundle compliance from 2015, and that was the average well into 2016. You know, there were some months we were up to 70%. You know, and as we recognized more and more, we treated it more and more. And that led to the fruits of our labor. And so once it's recognized, and you know that's where all of the literature goes back, once it's recognized, and if it's recognized early, it's easy to treat. But once it's easy to see, it's hard to treat. And so we really honed in on that vague presentation for them. So if you look at our mortality rate reduction, it was 39% from 2015 to 2016. And with that, that sums up the ever-evolving role that I have. So in broadening my perspective, we have partnered with local EMS services to promote even earlier recognition in the field. We have partnered with the Antibiotic Stewardship Committee to ensure that we're doing the right thing with every patient and to prevent an increased antibiotic resistance, and which I will say that our CR rates have actually gone down since starting the sepsis program. I've partnered with the infection preventionists just to be sure, right treatment, right time, right patient disease and process and bacteria. And in rounding on patients, you know, just to make sure that the sepsis is resolving, if it is not resolving and the patient is not progressing, then we, you know, will, at that time, I will have a crucial conversation with the attending and make recommendations for transfer to a higher level of care where more services are offered. Also, with providing bedside education to nursing staff on sepsis disease process and to promote early recognition and identification of risk factors from developing the syndrome again. And also, that is given to our patients. So a lot of my patients actually know me by my first name by the time they leave here, because, you know, I do establish that relationship with them to make sure that they understand that they're at really high risk for developing this disease process again. And with that, that is the conclusion of my presentation.
Thank you, Amy. I can't say enough the impact Amy's role has had on her organization. When I first visited, I was just blown away by not only their data results, but also how she's evolved the role and how she has really worked to develop her team in all areas of the hospital. So with that, again, thank you, Amy, and I would like to know if there are any questions. We have, just before we start our survey results, I think are final. So 28% of hospitals on the line have responded to yes, they do have a dedicated sepsis coordinator. 56% said no, and 16% are not sure. So Are there any questions for Amy? You can either type into chat or you could raise your hand.
Wanda, this is Kathleen. I'd like to ask Amy a question. Amy, do you also do real-time coaching with physicians as well as nurses?
Oh, yes, absolutely. Basically how the system works is if I'm in-house, I will go down and assist with the sepsis alert. And we may even make decisions like for meningitis, for example, 2 grams per second, or, kind of help navigate right antibiotic to right source. And also with nurses, it's all one-on-one. It's constantly speaking to the provider about the data that you're receiving and also about the interventions that you've performed. And it's constantly, it's the why behind the what, essentially. It's not just we're giving antibiotics to fight this infection, but we're giving antibiotics to stop the infection that's causing the cytokine release, which is producing the nitric oxide, which is what we're ultimately up against. It's constant discussion.
So was there a financial benefit? Because one of the concerns that people have around the country is, how can anybody afford an FTE for this role?
I'm sorry, Kathleen, could you repeat that one more time?
Around the country, some people are challenged with how can we afford full-time equivalent employee salary for a role like this. So have you found financial benefit to what your role has been doing?
Oh, absolutely, tenfold. When you reduce mortality and also reduce ICU length of stay, sometimes by days, you see these people, they'll look horrible that night, go into the ICU after they've been treated for sepsis, and they're well enough by next day, midday, to be downgraded. You've reduced your length of stay on this patient population where otherwise, normally, if not been treated and caught early, it wouldn't have been.
Awesome. They
have room for decompensation without treatment. And you're kind of reducing that ability in that room, doing everything you can to stop it.
Okay. Any other questions? If not, we will proceed with the presentation. And, if you think of something in the meantime, we do have some question time at the end of today's presentation. So, Ashley, again, thank you so much. And keep up the good work. And I am going to introduce Kathleen Bowman, who is going to talk about let me see if I can move the slide here. Here we go. She is going to talk about the, sorry, just one second. Okay, we have a mouse that seems to have a mind of its own. But Kathleen is going to talk about early screening and, here we go, with triggers and tools. And as you know, Kathleen is our subject matter expert for sepsis and travels the world speaking about sepsis and all of the components to successful treating and good patient outcomes. So Kathleen, the floor is yours.
Good morning or afternoon. I think it's still morning. I'm just checking to see, there we go. So basically, if you remember the motto, the next step after you ensure house-wide consensus for aggressive treatment and management, with part of that being the sepsis coordinator role, the next step is really looking at how do we find the humans. And what that includes is developing a screening process for the emergency room, rapid response, ICU, and also house-wide, including specialty units like OB, labor and delivery. Another component of this section of the model is developing an audit process, because it's important not to just, oh, somebody checked a box, but is that box checked accurately, and also are there clear steps to find for the nursing staff to take if they do have a positive screen. So why do we want to find these patients early? When you look at present on admission sepsis, and you take a look at mortality rates associated with that, and then not present on admission. So we have significant opportunities to be able to find these patients both in our emergency rooms and also within our entire hospital. So we've really got a good opportunity. So screening was initially brought up in 2012 guidelines, and it was given a 1C, a high recommendation, medium level science. And in 2016, because they changed strategies, they called this a best practice statement. We recommend that hospitals and hospital systems have performance improvement programs for sepsis, including screening for acutely ill, high-risk patients. So that basically tells us we need to do something to help find these. Now, for most of us, if you've been at this journey of managing critically ill patients for a while, the septic patient showed up and everybody recognized him because this was the patient laying on the gurney, supine, with the breathing machine, fluids wide open, increasing need for Levophed, and back in the old days it was called Levophed Leave 'em Dead, and the patient was minimally responsive. But now that we're finding patients sooner, these patients may be sitting up in bed, a nasal cannula, they're getting boluses, they need a vasopressor, but it's being weaned. They're awake, but they're presenting lactate with 6. And so oftentimes one of the biggest challenges we have is the emergency room calls the ICU, describes this patient, and the ICU may say, well, that patient doesn't sound sick enough. And the challenge is if they don't get their 24 hours or 36 hours, as Ashley talked about in the intensive care unit, they will decompensate and have a protracted course of this. So we have to sort of change the way we view it. Efforts to just recognize sepsis alone are not enough. In order to successfully reduce the mortality, we've got to catch it early. And early recognition is really a good portion of what has been shown to significantly reduce the mortality rate. And without that recognition, the clock is ticking, and that's that perfusion clock, the inability to get blood flow to the tissue. So I'm going to start somewhat basic because I think it's the foundation. So I think it's important because this is what makes up the sepsis screen. And I will address the sepsis 3 definitions and how this fits in with everything. But literally, the reason why this disease is so difficult is because it rests on a disease continuum. And we have to figure out the exact point at which to do the full court press for the patient. So let's start at the beginning. A known or suspected infection. How do we know somebody's infected? Well, if I'm in the hospital and the patient's on antibiotic and it's not post-op surgical prophylaxis, somebody thinks they're infected. We also look at blood cultures, we also look at fever, we look at white count, we look at pus coming out of someplace as a part of it. One of the things that we also discovered in our work, especially in the emergency room triage area, patients with severe sepsis present with interesting chief complaints sometimes that would not seem like sepsis. And so one of the strategies that's been very effective in many of the institutions we've implemented the model is that no matter what the patient's chief complaint is, to literally ask the question, are you currently on an antibiotic? Because that allows belly pain, you know, things that don't look like infection for you to be able to capture them on an early perspective versus sending that patient back to sit down. So that's the first part of the screen, is identifying, does somebody have a known or suspected infection? The next thing is to ask, did that bug or did that infection ignite an inflammatory response in the body? And that's the SIRS, Systemic Inflammatory Response Syndrome. Now, if you think about the patients that we care for in the intensive care unit and also in med-surg, they only need 2 of these: a temp greater than 38 or less than 36, heart rate greater than 90, respiratory rate greater than 20, a white count greater than 12,000 or less than 4,000 or greater than 10% immature bands. And 2 additional criteria were added to SIRS when the Surviving Sepsis campaign launched, and that is a blood sugar greater than 120 in a non-diabetic, and acute mental status change, which is actually an organ. But Dr. Dillinger talked about the fact that they identified acute mental status change as one of those presenting symptoms both in the emergency room and in the med-surg that cue people in that the patient's status has changed. So if you think about it, almost every patient in the hospital has 2 of these. Because we don't admit people until they have an inflammatory response going on to where they're sick enough. And so it's really about tying that SIRS criteria to that known or suspected infection. But I'd like to drill down just a little bit, because in all the data published around sepsis, there are some additional signs and symptoms, and from the journey that I've taken through my career, there are a couple that have shown up that we really need to teach frontline staff something different about. And so tachypnea, I would like to focus on 2 of these: unexplained tachypnea and unexplained hypotension. The way we need to teach them is literally those are medical emergencies. I talk to audiences all over the world, and I describe this scenario that I'm going to share with you. Patients breathing 34 a minute. They're sucking for everything they own. They got the intercostals working, and the SAT monitor says 97%. And so the nurse calls the physician, describes the patient. If they're on the med-surg, they may get an order to draw blood gas. And actually, if you want, you can write down this blood gas. I'm going to give you an example. A pH of 7.36, a PaCO2 of 28, a PaO2 of 70, a SAT of 97, and a bicarb or CO2 content of 18, depending on whichever your facility uses. And the nurse provides that information over the telephone, and the response they usually get back, keep an eye on them. Because I'll tell you what happened. They heard a normalized pH, jumped to the oxygen, and made the evaluation. Because of the SAT monitor, it's almost become a detriment to full respiratory evaluation. So if you have somebody breathing like that, it is the body's emergency way, and they're not supposed to be breathing like that, like a COPD. It's the body's emergency way to get rid of acid. So if we don't step on it, and literally this patient was close to being a decompensated metabolic acidosis. If we don't jump on it and escalate it up to a rapid response for evaluation, we may end up having a patient with the next call of respiratory arrest, room 205B, as a part of it. So that is one. The other is unexplained hypotension. So what do I mean by unexplained? In other words, I just didn't give the patient an antihypertensive med, or I didn't just give them a sedative or a pain med as a part of it. So an example of this is the patient drops their blood pressure, and the nurse's usual response is to call the physician, share with them the data, and oftentimes the physician's response is give them a 500 cc bolus. By the way, it used to be 250. It's jumped up to 500 now. And so the nurse gives that bolus, and the blood pressure goes up just enough that they don't have to call, and then it drops again. And so they make another call. And what do they get again? Another 500 cc bolus, just enough that the blood pressure stays up until it drops again, or they give report to the next nurse and it's somebody else's issue. So we actually have patients that need to be resuscitated in a short period of time, having that extend over time. So what I recommend is that if a patient is experiencing an unexplained hypertensive episode, that the nurse should consider rescreening for severe sepsis. So something to think about. Also, I don't know if your organization has changed the way they measure urine output. So if they're not measuring urine output 0.5 cc's per kilogram per hour, and they're doing the 30 cc an hour is adequate kidney function, just think about this for a second. The entire adult population in the United States has good kidney function if they pee 30 cc's an hour. Pretty bizarre. Why weight-based? Now, our PD and neonatal have done a good job of doing weight-based for everything. But just for an example, I have some extra adipose tissue on me. And it has to be vascularized, otherwise it would become necrotic and fall off, and by the way, I'd be really happy about that, but that doesn't happen. Now, it isn't as vascularized as other organs, but it's still vascularized. So therefore, larger individuals have a larger amount of urine that they should be putting out, and so therefore we should be basing it on weight. Skin modeling, this is a sign and symptom. If you take the sheet back and the knee is modeled, it's one of the first places where low perfusion shows up on the skin. And hyperglycemia, because the body's in a fight or flight reaction, and if you wait for purple petechiae, you probably waited too long. So when we put the known or suspected infection and those SIRS criteria together, we have the definition of sepsis. Now, this used to be called simple sepsis in the fact that I don't have an acute organ dysfunction. Where this whole process starts and the bell dings, and I would suspect, Ashley, this may be where the sepsis alert comes in, is where we have the known or suspected infection, the two SIRS criteria, and we have an acute organ dysfunction. And what do I mean by an acute organ dysfunction? Basically, acute is the word. They had a blood pressure, they don't have one. They were peeing, they're not peeing anymore. They were breathing on their own, they now require an increased amount of oxygen support. They were making sense, they no longer make sense. And so that gives you an idea of what the difference is of acute versus the chronic. Now, what is the difference between severe sepsis and septic shock? Basically, shock is an unresolved perfusion deficit, and it is defined in this context as failing the initial 30 ml per kilogram bolus and or having a presenting lactate of greater than 4. So when we look at this criteria, and this is criteria that you will find on almost all the screening tools that are out there, and some of the examples we did provide for you. So there's a neurological component, a respiratory made easier by a SAT less than 90 or a patient is experiencing increasing oxygen requirements, an abnormal serum lactate, so that is considered a metabolic organ, need for vasopressors, urine output as we talked about, or creatinine, and then platelets or an INR. So that will, with no other reason. Remember, this is acute organ dysfunction. So I wanted to provide some examples of screening tool. Now, what I will share with you, the initial screening tools that came out with known or suspected infection on top, and it had a bunch of where do you think the infection is. Now, because these screening tools are actually being completed by the registered nurse, where they think the infection is not really within their preview to document. That's really part of the physician's differential diagnosis. So what most places have gone to is the known or suspected infection. Are they on previous antibiotic therapy that's not post-op prophylaxis? So I wanted to bring that up. The second thing I wanted to bring up is most organizations have now put the SIRS criteria first, because what was happening is sometimes the infection question would get blown by fairly quickly. But from a human behavior perspective, if the nurse is checking off for SIRS criteria, they're going to pay more attention to the infection question. And so that's why you see in this particular tool, the SIRS criteria is first, infection is second, then the description of the acute organ dysfunction, followed by an actual SBAR communication. And literally, the rapid response is initiated when all three of those are present. If I only have two, the known or suspected in the SIRS criteria, there is a recommendation to screen more frequently, potentially do serial lactates for a 24-hour period as a part of that. So where some individuals get tired sometimes of there's too many false positives is they call sepsis alerts on the known or suspected infection and the two SIRS criteria instead of waiting for that acute organ dysfunction. And I apologize that this is a little fuzzy, but you do have the attached tool to be able to download. It is also part of the HERT sepsis package as well. So in this particular hospital, if they are diagnosed and meet the criteria for septic shock, this hospital activates a code sepsis, and it's an automatic transfer to the intensive care unit. They have a differentiation. If the lactate is elevated or initial hypotension responds to the 30 mLs, then they recommend transfer to an intermediate care unit. And so needless to say, this is a direction for an emergency room or on the floors. And if the lactate is abnormal and no cardiovascular component, they have a general, they admit them to a general care ward, so this would be classified as simple sepsis with an acute organ, so that would be severe sepsis, but no cardiovascular involvement. And so each of those have care bundles associated with them so that they can monitor the direction the patient goes in as a part of his journey. So this is an example, another one. I wanted to include different ones. As you can see, they also, so they particularly have the infection question first in this one, then they have the SIRS criteria and acute organ, and then they literally have the next steps based on the answers to the survey or to the screening tool. And then this is an example in the emergency room as a part of that. So, and what we've discovered is that in the ER, it should actually be at triage and then repeated again because most organizations are having extended ER lengths of stay. And so therefore the patient should be rescreened because they may be negative in triage and may be positive later on. So the key in this, and then I wanted to give you an example of an L&D and also alert you to the fact that there is an L&D free webinar about maternal sepsis that is being put on by the CDC and the Society of Critical Care Medicine. That is tomorrow, I believe. Wanda, did we put that information in?
I forgot to, but I will send it out to everyone following the webinar. Thank you for the reminder.
No worries. So I wanted to show you, and I don't know if you can see this, but what is different in this L&D screen is for pregnant women, the heart rate burden is greater than 100. the WBC's greater than 20,000 in labor. It's still 12,000 not in labor, but where it differs across the entire pregnancy, labor or non-labor, is greater than 5% immature bands versus greater than 10%. So that is where you get some differentiation between pregnant and non-pregnant individuals as a part of it. So, well, hold on, before we do the polling question. So do we have the polling question?
Yes.
So before we put the polling question up, I wanted to share with you, when I'm asking these polling questions, I'm talking about the screens I described, where within assessment, they are doing the SIRS criteria, the known or suspected infection, and the acute organ dysfunction, for as much as they can, especially in triage because you don't have some of the laboratory data. Okay, so we can start.
Yes.
Do you currently screen every patient in triage?
Okay, we're just waiting for the results here.
No worry.
I feel like I'm watching the Kentucky Derby, you know.
Or we could do Jeopardy. No, 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 no.
Yeah. So it looks like we have 63% say yes, they do screen every patient in triage, 17% no, and 24% are not sure.
Okay, so this is an opportunity for those that aren't doing it. Every patient should be screened, even the ones that you think look like they wouldn't need it. It's a safety factor. It's as critical as doing your chief complaint. So the next polling question.
Okay. Well, do you want to move the screen down, Kathleen, and then we'll put up the poll?
Why don't you?
Okay, there we go.
Do you rescreen in the ER? Because sometimes the triage computing system and the regular documentation system is different. And the reason why we're polling these is because this is the crux of being successful in identifying early.
So in this case, regarding rescreening in the ER, we have 32% yes, 32% no, and 36% not sure. So I will say it's a tie, a three-way tie.
Well, and so what's exciting is these are opportunities for organizations to show up and not miss, because the rescreen in the emergency room is critical because you don't want to send a patient to the floor because the data, if they meet criteria, because the data clearly shows that if they get admitted to the floor, they decompensate fairly quickly and go to the ICU, their mortality rate is significantly higher. So you can move to the next one.
Yes. Mm-hmm.
So do the nurses screen as part of the shift assessment in the ICU, very much like they do Braden or the DVT risk screen or delirium risk screen?
Okay. Good. We'll just give it one more second here. All right. We have 48% yes, 40% no, and 12% not sure.
Okay. So again, another opportunity. So, so these are additional polling questions that I'm going to ask. Did the nurses screen as part of their shift assessment in the med-surg area?
Kathleen, while we're waiting for that poll, could you talk a little bit about the identification of high-risk patients for screening versus the patients that have to be screened regularly?
And I will share with you, in most of the organizations that have embedded screening, it's done on every patient. And that's because the patients in the med-surg area used to be in the ICU 10 years ago. So right. we don't hospitalize people unless they're fairly sick. And when you look at, if you try to differentiate high risk, the challenge is it's like differentiating, you don't know who's high risk unless you screen.
Right.
Sort of like the Braden scale. It determines the high risk and what actions you should take. And so that's why it needs to be done every day or every shift, every patient by the nurse.
Thank you. I have the results here, 45% yes, 36 no, and 18% not sure.
Okay, so very similar. So it seems like they're a group that have blanketed the screening throughout their entire organization, and there are ones that don't. So one of the things I would recommend for those that have not launched or embedded screening is definitely start with your emergency room and your ICU. And also ensure that your rapid response team, every call they go to, they screen for severe sepsis, because they're evaluating for heart attack, they're evaluating for stroke, but unless you ask those 3 questions, it's very difficult to evaluate for severe sepsis or septic shock. So I'd like to ask, is anybody assessing in a shift assessment in the labor and delivery area?
Okay, well, it looks like we have 35% yes, 48% no, and 17% not sure.
Okay. So another opportunity. So one of the first places I worked at, and actually the nurse is going to be on the webinar tomorrow. She attended the first education I gave, and this was probably in 2006, and she started working on it. And even before they had vetted the screen, just through education, they had a tremendous number of saves. Their organization was in a lower socioeconomic area, and so a lot of patients had not gotten prenatal care, and so they had a lot of good success with catching early. All right.
Okay.
Go.
We close that. No, not that. And then you can move to the next screen, Kathleen.
Okay, that's what I'm doing. There we are. Oops, whoop. All right. And this is another point I wanted to bring up. And a lot of hospitals are maybe in the transition of paper to electronic. And also some individuals may think that the Muse score is sufficient enough to pick this up. The computer behind the scenes screening should be classified as what IHI calls an independent redundancy or a secondary screen. Because what we have discovered with organizations that said, oh, we've got this electronic now, the nurses don't need to screen in their shift assessment, they lost the skill sets and therefore didn't respond as significantly to the best practice alerts that came up. So the other recommendation on this is if your organization is converting to electronic and you can't get the screen put in right away and you've been placed on the list, which most of us know what that is, on, you know, putting a long list going, I want to be next, use paper. Don't wait to just launch this electronically. There is data that's been published now through the Surviving Sepsis campaign showing early recognition through screening in the med-surg unit has significantly reduced mortality. The paper form, it's a visual cue, no cost. Now the screening's intermittent. The paper may get displaced, but if it becomes part of their world, then when you get it populated onto the computer, it'll make it easier for them. So what I recommend is that when you get a Muse alert or when you get a best practice alert related to sepsis, that the nurse actually does a physical screen and goes through those SIRS, known or suspected infection, and acute organ dysfunction criteria. So it's really about making this woven into the way people do business. So weave it into their practice. They should do the screening every shift and PRN when conditions change. And those condition changes would be the unexplained tachypnea, the unexplained hypotension, and probably acute mental status change. If you remember, Ashley talked about having sepsis champions. Those sepsis champions can help do audit of screening for not just compliance of tick in the box, but also for accuracy. And screening for severe sepsis with every rapid response or medical response team. And then it is absolutely critical, and you saw it on some of those screens, that the next steps with a positive severe sepsis screen or a positive shock screen that the nurse should be taking. So when we look at the Surviving Sepsis campaign best practice statement, they said severe sepsis, but they also, so they took on the new definition of sepsis, but that's why they put it in parentheses, severe sepsis, and septic shock are considered medical emergencies, and we recommend that treatment and resuscitation begin immediately. Now, I want to share with you an interesting behavioral phenomenon related to sepsis that I've witnessed over the course of my consultation and work in sepsis. Is in our emergency rooms and also the floors and ICUs, it's a heart attack until we can prove otherwise. When somebody says, I have an elephant sitting on my chest. It is a stroke until we can prove otherwise. But it's different in sepsis. What we always hear is, oh, I don't think it's sepsis, I don't think it's sepsis, I don't think it's sepsis, and then it's sepsis. And we're too far down the line to impact mortality. So when you consider a good portion, if you remember the webinar on Tier 1, the percentage of mortality in a hospital, the number of deaths, the majority, 2 out of 3 deaths in a hospital is related to sepsis. Why then would you not go, this is sepsis, until I can prove otherwise? So something to think about and determine how individuals in your organization view that construct. So the practice definitions that are currently being used by CMS and coders are the ones that I walked you through with regards to screening. Do I have a known or suspected infection? Do I have the SIRS criteria? Severe sepsis is defined as an infection plus 2 or more SIRS criteria and a new organ dysfunction. And septic shock is severe sepsis with a lactate, presenting lactate greater than 4 or a failed fluid bolus. So this is what CMS and the coders are still using. So that's why your screen still needs to incorporate that as a part of early recognition. So to talk just briefly about Sepsis 3, the HURT document has adopted the new definition of sepsis. The Surviving Sepsis campaign has adopted it. But in the practice world, we're still calling it severe sepsis and septic shock. So sepsis defined as a life-threatening organ dysfunction caused by a dysregulated host response to infection. So this third iteration of a sepsis definition removes the SIRS criteria, severe sepsis, and sepsis syndrome and septicemia. How is septic shock defined? It includes the life-threatening organ dysfunction caused by a dysregulated host to infection, but also vasodependent hypotension and a lactate greater than 2. So that's the definition. So they also went through a significant amount of retrospective data to come up with what is called QSOFA and SOFA variables that predict patients at high risk of death. So how do these come into play? Right now, you really need to be doing what you're doing, continue with the previous description of the screening, and if you want to add QSOFA or SOFA scores to your process, you can. But the challenge is, at this point in time, so QSOFA, respiratory rate greater than 22, altered mental status, and a blood pressure less than 100. The data indicates with 2 or more of these, they have a significantly greater risk and have a prolonged ICU stay or are likely to die in the hospital. And same with a certain SOFA score. So in essence, it's more of a predictor of mortality than it is a sepsis screen. So the challenge is that QSOFA or SOFA, it's an illness severity score that predicts mortality. It was designed to predict the badness of the disease, but they are not necessarily early risk screens to pick up patients in severe sepsis. So if you are screening for sepsis, what are you using to screen? So we have this polling question. Now, what we probably should have put in here is the previous screen as well, what we talked about.
Right.
A boo-boo on our polling.
So it looks like we have about, let's see, 38% are using the known or suspected infection more than 2 SOFA or QSOFA symptoms. 28% are using Muse. 17% said they're not screening, and 17% are not sure.
Okay, so, and I'm not exactly sure, and we don't have a way to ask you, but those that are using known or suspected infection with the QSOFA or SOFA, even the Surviving Sepsis campaign says that you should include the SIRS criteria as a part of it, and you shouldn't, you should use these as adjunctive because they're more predictive of mortality and they have not been studied prospectively. So that's the difference, retrospective, prospective. The screen that I talked with you about was studied prospectively. Nope. Trying to move forward.
Let's see.
There we go. So it's also somewhat incompatibility with our current QI efforts. They're mortality predictors, not screening definitions for early identification. CMS definitions and core measures have not changed. ICD-10 codes have not changed. And at this point, how do you transition because you're being measured on something different? So those are all points to think about in your journey. But the HERT sepsis mortality reduction talks about reliable early detection, implement a sepsis screening tool, adopt sepsis screening of all potentially infected patients, which, by the way, if you actually do a query of how many patients in your hospital are on an antibiotic, you'll find out that they fit the 80-20 rule, which is why you screen everybody. And then support timely interventions, and we're going to spend more time on that in the next couple of webinars. So when you look at your sepsis program action plan, we're talking about defining the screening tools and process for the emergency room, the ICU, the floors, and rapid response, and then how are you going to audit that process to make sure people are educated in doing and knowing what they need to do as a part of it. And so I'm going to hand it back to Wanda for the last couple of slides to just follow through.
Great. Thank you, Kathleen. Okay, it is just about 12 o'clock, and I know our webinar just goes from 11 to 12, but I do want to give an opportunity to ask questions. My slides are basically just kind of project update, box reminders, and I can certainly email these to the participating hospitals. So I'd like to just open the session to questions now. And as I said, there are, some data slides that you can review on your own, and then also just some reminders. But if there's any questions for Kathleen, you can either raise your hand or type a question in chat. Also, if you have questions for Ashley, you could include those as well. Okay, I don't see, I think we have a question here. Okay, here's the question. Could you have Kathleen repeat the blood gas values you gave when you were giving the scenario, Kathleen?
Sure. pH of 7.36, PaCO2 of 28, PaO2 of 70, saturation 97%, and a bicarb or CO2 content of 18. And basically what happens is we oftentimes skip over the PaCO2 and the bicarb and look just at the pH and the oxygenation, and that results in not catching early what is going on as a physiologic rescue measure for increased acid. And when you have increased acid buildup, it's an emergency, whether it's DKA acid, salicylate poisoning, or lactic acid from perfusion. It's a medical emergency and needs to be addressed.
Thank you. Any other questions?
By the way, just to remember, guys, you all have my email address, so feel free to contact me as you work on this, but I can't press upon you how important. You will have significant challenges with time zero and initiating your bundles without a screening process to launch it.
Wanda, I just wanted to add one more thing to today's presentation that I actually just thought of. We did a little intrinsic study with our screening process, and once we fully were up and running with the sepsis program and catching those patients with our screening tools in triage and in the ER, we had a 75% reduction in in-house code blues and in in-house rapid responses.
Makes total sense, Ashley.
Yeah, wow. Thank you for sharing that.
Yeah. So basically, the message is these tools and triggers, they work. You've heard from one of your colleagues, practical application, and seeing the outcomes. And what we're sharing with you is what's happening around the country to help meet the ability to recognize and manage these patients. So I look forward to the next webinar.
Okay, so with that, I just want to thank once again our speakers. Ashley, thank you so much for sharing your experience and your success at Lewis Gale Montgomery Hospital. And Kathleen, once again, thank you so much for your insights and guidance on this project. I will follow up with an email to the participating hospitals with that CDC and critical care webinar on the labor and delivery sepsis screening and care, and also with just some other project updates. So thank you everyone for participating.
Have a great day.